Hello, I'm Dr. Petros Grivas. Thank you so much for joining us today for the educational session, Tailoring Patient Care Using Novel Agents in Metastatic Urothelial Carcinoma, Strategies for the Interprofessional Team. Today's presentation is brought to you by Creative Educational Concepts and is supported by an independent educational grant from Gilead Sciences. Again, I'm Dr. Petros Grivas. I'm a medical oncologist in Seattle. I'm a professor at the University of Washington and Fairhax Cancer Center, and I'm serving as the clinical director of the Genitourinary Cancers Program at the University of Washington and Fairhax Cancer Center. I'm really thrilled and really excited to be joined today by two wonderful colleagues, excellent, I would say, practitioners and investigators. A good friend, Dr. Daniel Petrylak. Dr. Petrylak is a professor of medicine and medical oncology and urology. He is the chief of the genitourinary oncology at Yale Cancer Center and Yale School of Medicine in New Haven in Connecticut. Hi, Dan, and thanks for joining.
Hi, Petros. How are you?
And also, we're very, very excited to be joined by Taran Sims. Taran is a nurse practitioner with great expertise and great reputation in the field, also in educational events. Taran, she's practicing in GU oncology at the University of Virginia Health System in Charlottesville, Virginia. Taran, thank you so much for joining us.
Welcome, and thanks for letting me be part of this.
Wonderful to have you both. And I would say that we have a series of objectives today. And I think all the three of us working together will be great to try to tackle those objectives and try to deliver the educational mission. The first objective is to assess the evidentiary base for antibody-drug conjugates in metastatic disease, including regulatory updates, recent readouts, and current expert consensus guideline recommendations. Also, we plan to utilize evidence from pivotal clinical trials in metastatic urothelial carcinoma to develop personalized antibody-drug conjugate-directed treatment regimens based on patient and disease-specific characteristics. Moreover, we want to implement an interprofessional multidisciplinary approach to adverse event participation and anticipation, I would say, and recognition, early diagnosis and management of adverse events in patients with urothelial carcinoma treated with antibody-drug conjugate-based regimens. And I think that's a very important component. As you know, the more we anticipate those adverse events, I think the better we can manage our patients with timely recognition, diagnosis, and optimal management. And I think, Taran, you will help us a lot with that component as well. So there are definitely multiple unmet needs in urothelial carcinoma, and I want to focus your attention on the left part of the slide. You see that a significant proportion of patients present with what we call localized bladder cancer, especially what we used to call back in the day more superficial bladder cancer. The modern definition and the way we say this is not muscle invasive bladder cancer, meaning the bladder cancer has not invaded the muscularis propria. So we talk about a clinical TA or carcinoma in situ or T1 states, and it's important for our urologist colleagues to do proper staging and make sure we do not understage a patient, which is common, especially in this differential between T1 and T2, non-muscle invasive versus muscle invasive stage. So imaging, exam under anesthesia, and also PT, transurethral bladder tumor resection, is important in order to optimize the staging, the clinical staging of those patients. And of course, as you see, a very small proportion, I would say, approximately 5% of patients who present with a new diagnosis of bladder cancer present with metastatic disease. So the majority of patients with a new diagnosis have earlier disease states, not muscle invasive or muscle invasive. However, some of those patients may eventually progress to advanced or metastatic urothelial carcinoma. So we have many patients who may progress from early stage to later stage. On the right part of the slide, we see a representation of the prognostic estimates depending on the stage. As I mentioned, the majority of patients with more superficial or not muscle-invasive bladder cancer usually have a long-term survival. You see that more than 97% are alive at 5 years if they have only carcinoma in situ, one of the types of not muscle-invasive disease. And as we go through the stages, with muscle-invasive disease, we may have a drop in 5-year survival. When we have regional metastasis and eventual distant metastasis, we have a significant drop, as you see with patients who have metastatic urothelial carcinoma. Less than 10% of those historically have been alive at 5 years. I would say, though, that with recent regimens, and we'll discuss those today, we're hoping that this proportion is higher. So we're hoping that this less than 10% may hopefully be double these days, and maybe more than that, so we can see more and more patients being alive at 5 years and beyond with more effective systemic therapies. And I think that's a hopeful message for the future. I want to also point out that platinum-based chemotherapy has been traditionally the cornerstone of treatment for metastatic disease. As I mentioned, we have now some recent developments. We covered those today with Dan and Teran, and want to also pay attention not only to efficacy, but also toxicity profiles of those combination regimens and single agent therapies. And now we, as I mentioned, we have a plethora of more options compared to what we used to have in the past. We have, in addition to chemotherapy, conventional cytotoxic chemotherapy, we have antibody drug conjugates, we have immune checkpoint inhibitors, and we have a targeted therapy, erdafitinib, that inhibits FGFR. So Dan, I will pass it to you to present this case, and thank you so much for joining us today.
Thank you, Petros. It's certainly a pleasure to be here today. So this is a 63-year-old smoker who developed gross hematuria. And on examination, on cystoscopy, he was found to have a large bladder mass. A TURBT demonstrated a high-grade urothelial carcinoma with muscularis propria invasion. He underwent a CT scan of the chest, abdomen, and pelvis, which demonstrated a bladder mass as well as multiple pulmonary nodules. He had a creatinine clearance of 40 milliliters per minute, and his PD-L1 expression was 0. So what's the optimal management for this patient? Gemcitabine cisplatin, enfortumab pembrolizumab, carboplatin gemcitabine, followed by avelumab maintenance if there is no progression, and then nivolumab gemcitabine plus cisplatin. So my choice for this would be enfortumab and pembrolizumab. I'm going to review the data for that. So we know that the paradigm shifted for locally advanced or metastatic urothelial carcinoma. Traditionally, platinum-based chemotherapy has been the standard of care. However, with cisplatin, with renal insufficiency, that may limit its use. Additionally, with carboplatin, some patients may not have the performance status to have carboplatin-based regimens. So that's led us to look for newer treatments. And with these newer treatments is coming a shift in the disease. So for those patients who had organ-confined disease in the past, we had used neoadjuvant chemotherapy that was cisplatin-based. That could have either been MVAC or gemcitabine cisplatin. And then the patients went on to cystectomy. If the patient had residual muscle invasive disease, then it was appropriate to consider adjuvant checkpoint therapy for these patients. There are also bladder preservation protocols that can be used to maintain the bladder, and these include chemotherapy and radiation therapy. First-line metastatic therapy in the past had, as I mentioned before, had been gemcitabine and cisplatin or gemcitabine and carboplatin, and then afterwards checkpoint therapy and ADCs were used as second and third-line therapies respectively. That also included drugs such as erdafitinib for those patients who are FGFR3 positive. So these are the current NCCN guidelines, and we'll discuss some of the data that supports this. So the category 1 preferred treatment for cisplatin ineligible as well as cisplatin eligible patients is the combination of enfortumab with pembrolizumab, gemcitabine, and cisplatin for cisplatin eligible patients, and then avelumab maintenance is also considered to be a preferred regimen. And same thing with nivolumab, gemcitabine, cisplatin. Then for a preferred regimen for those patients who are cisplatin eligible, if they can't receive enfortumab pembro, then gem carbo followed by avelumab maintenance would be appropriate. Post-platinum, second line, pembrolizumab is FDA approved. Nivolumab and avelumab are also FDA approved in this situation. And then for those patients who are FGFR3 positive, erdafitinib would be appropriate. And certainly enfortumab vedotin is also an appropriate drug as well. Now, this is where it gets to be a little bit confusing because our second-line therapies are dependent upon what the patients have received previously. So you've gone down the path of a platinum-based chemotherapy regimen, then pembrolizumab. It's appropriate to give enfortumab combined with enfortumab vedotin as a single agent. And that's based upon the EV301 studies. In those patients who received enfortumab pembro as first-line therapy, one could give either gem-cis or gem-carbo, depending upon whether the patient has neuropathy or not. And then also erdafitinib could be administered in those patients who have prior FGFR3 positivity. In other regimens, again, as I said, gemcitabine cisplatin for those patients who are not neurologically compromised, also dose-dense MVAC. And then in third line, we have sacituzumab govitecan and other single agents such as gemcitabine, paclitaxel, docetaxel. Those all could come into play. We also know that trastuzumab deruxtecan is also appropriate for those patients who have HER2 positivity IHC3+. So what's an antibody-drug conjugate? Well, what's the conjugate between an antibody and a cytotoxic agent? And there are different parts of these particular molecules that are important to its function and activity. So these are these target molecules that are highly expressed on the cell surface and also have limited normal tissue expression. These drugs will internalize after they bind, and conjugation sites for the drugs, either cysteine or lysine, should not impact on the stability, binding, internalization, or pharmacokinetics. The linker is what links the antibody to the drug. It's stable in circulation. It should be stable in circulation. It should have selective intracellular release of the biologically active drug through either enzymatic cleavage or degradation of the monoclonal antibody. And there should be limited heterogeneity of this particular product. So these drugs are highly potent. They're amenable to modifications that allow linker attachment. They're stable in circulation as well as in lysosomes. And the question also is there a local bystander effect from these drugs? In other words, is drug released in the interstitial area between cancer cells that it may have other cytotoxic effects and multiply its activity? The two of the three FDA-approved ADCs are depicted in this slide. On the left is sacituzumab govitecan. On the right is enfortumab vedotin. They have different linker technologies. For sacituzumab, it's a hydrolyzable pH-sensitive linker, which links SN38 to the molecule itself. And approximately 6 molecules of SN38 are linked to one molecule of sacituzumab govitecan. And then enfortumab vedotin has a protease cleavable linker, and it links this to monomethyl auristatin. The antibody recognizes Nectin-4 as opposed to sacituzumab, which recognizes TROP2. And then these are delivered to the cell by this particular mechanism. They bind to those particular proteins, and they're internalized. And as I mentioned before, with sacituzumab govitecan, with SN38, that will target topoisomerase 1, as opposed to tubulin, which is targeted by enfortumab vedotin. So EV302, this was a randomized trial with patients who had previously been untreated for urothelial carcinoma, and they were eligible to receive platinum, EV, and pembrolizumab. They were PD-L1 naive. They had to have a GFR between 30 and 60 and ECOG performance status of 2 or better. And 886 patients were randomized on a 1-to-1 basis to receive EV pembro. And there were no maximal number of treatment cycles for EV, but pembrolizumab was capped at 36 to 35 cycles. And this was compared to standard of care chemotherapy, either cis or carbo, combined with gemcitabine, and a maximum number of 6 cycles were administered. Patients were eligible, could receive maintenance therapy with avelumab if they had stable disease in this particular arm. There were dual primary endpoints: progression-free survival, as well as this was by the investigators, as well as an independent response committee, as well as overall survival. And secondary endpoints included objective response rate, as well as safety. Patients are stratified based upon platinum eligibility, PD-L1 expression, and the presence or absence of liver metastases. So this, I think, is the most important slide from this particular study. We see that there's a significant improvement in the overall survival of those patients who received enfortumab plus pembrolizumab, actually reducing the risk of death and progression by 55%. The median survival was progression-free survival is 12.5 months, in the enfortumab pembro arm versus 6.3 months in the control arm. That's pretty much a doubling of the overall median progression-free survival. And if we look at PFS by different subgroups, we see that it's maintained across all different subgroups, particularly, I think, which is interesting here, the visceral metastases versus lymph node only hazard ratios is very, very similar in those groups of patients. Same thing with cisplatin eligibility, PD-L1 expression, and also liver metastases as well. And that's something that we've seen in the past, that those patients on standard chemotherapy who have nodal disease tend to do better than those with visceral disease. That's not what's really seen here with So this is the overall survival with the median follow-up of 17.2 months. The hazard ratio is 0.47. And again, it's approximately a doubling of the median overall survival from 16 months to 31.5 months. And that's pretty impressive difference. Now, there are some caveats to this overall survival curve, which I think are important. Number one, not all patients receive avelumab maintenance on the control arm. And additionally, only about a third of patients receive enfortumab as second-line therapy if they were on the control arm as well. So that may have tightened survival curves had that actually been distributed a little more evenly. But nonetheless, this is a remarkable doubling of the survival benefits, survival in patients with metastatic urothelial. And this is a subgroup analysis for overall survival, very, very similar patterns to what we saw with the progression-free survival on the previous slide. So treatment-related adverse events. This is something that we have to keep in mind with this particular drug. Sensory neuropathy, pruritus, rash. These, I think, are the most commonly seen side effects with enfortumab combined with pembrolizumab. Additionally, we have some checkpoint-specific side effects, particularly diarrhea, fatigue, decreased appetite. But those are what we generally see with the EV pembro, probably a little more frequency than we see with chemotherapy. But overall, there's slightly less toxicity with enfortumab pembro as we see with chemotherapy. So a second trial that has been presented and published within the last year is Checkmate 901, which compares nivolumab combined with gemcitabine cisplatin to gemcitabine cisplatin alone in first-line metastatic urothelial carcinoma. This is based upon the hypothesis that there was a difference seen in the survival, a trend towards a better survival when cisplatin-based chemotherapy was combined with checkpoints up front than compared to carboplatin-based therapy. And that's why this trial focused on gem-cis rather than gem-carbo. So 608 patients who were previously untreated with metastatic urothelial carcinoma and were cisplatin eligible, having an ECOG performance status of 1 or better, were randomized to nivolumab, gemcitabine cisplatin, or gemcitabine cisplatin. And then if the patients responded on the nivolumab gem-cis arm, they went on nivolumab maintenance. The primary endpoints were overall survival, PFS per EICR, and then secondary endpoints were OS and PFS by central review in patients with PD-L1 of greater than 1%, and also health-related quality of life. So these are the important curves from the Checkmate 901 trial. As we see, there's a 28% reduction in the risk of progression or death when gem-cis nivo is compared to chemotherapy. In terms of survival, there's a 22% reduction in the risk of death when gem-cis nivo is compared to chemotherapy alone. So there does seem to be significant improvement in overall survival with the combination. So overall conclusion, 2 phase 3 trials in the first-line treatment, advanced metastatic urothelial carcinoma, have demonstrated improvement in overall survival. This is the gem-cis nivo versus gem-cis, and the EV pembro versus standard of care chemotherapy. Nivo gem-cis is the first chemotherapy to show survival benefit of 21.7 months. However, the combination of EV pembro also almost doubled the overall survival, making it the new preferred standard of care for the patients in the setting. So let's move on to the case continued. The patient undergoes treatment with EV Pembro and initially responds with 50% reduction in tumor burden. By week 9, he develops grade 1 neuropathy and grade 1 fatigue. What would you recommend for this patient at this point? To reduce the dose of EV to 1 milligram per kilogram and continue treatment, hold EV, monitor the patient until the neuropathy resolves, then restart at 1 milligram per kilogram and continue Pembro, and discontinue EV, continue Pembro, or continue the same dose of EV combined with Pembro. And this is one of the more difficult things to do in terms of managing the patient, trying to determine whether you should hold a dose or reduce it. So generally, I think you can hold the dose and until the neuropathy resolves, and then go back and restart the EV at 1 milligram per kilogram. But you can continue the checkpoints since that does not affect the neurotoxicity. Petros, what are some of your thoughts on the neurotoxicity of the situation?
Thanks, Dan. Great discussion and great presentation of data. You know, as you said, this is the case where we have a discussion with the patient, and I think asking their preferences and priorities is important. If it's just grade 1 neuropathy and grade 1 fatigue, although the label of enfortumab may say continue, in my practice, I tend to lower the dose of enfortumab in that case, as you alluded to, since we know neuropathy is very common, and probably more than half of the patients develop that side effect with enfortumab. I think we look for that and we anticipate that, we educate the patient. So my preference in a grade 1 neuropathy and grade 1 fatigue, if it's a change, that may be the time to lower the enfortumab dose to 1 mg per kg and continue treatment. And seems the patient is tolerating pembrolizumab well. I think the other factor that I take into account is the data you presented on at ASCO just a couple of months ago, which I think were very important data. The summary of your presentation, of course, you can comment on that, is that the initial dose of 1.25 mg per kg seems to be associated with high response rate, but subsequent dose adjustments, reduction or delays of EV based on toxicity and side effects in EV monotherapy trials did not appear to compromise outcome. So this gives us confidence to adjust EV as needed, and we kind of extrapolate in the EV Pembro data. So I think even if the label says you can continue for grade 1 neuropathy and fatigue, I tend to just lower the EV dose at that point. Any comments from you, Tara or Dan?
Well, all I would say is a lot of these patients have already had neoadjuvant chemotherapy. So we know neuropathies are a distinct possibility. I don't know if they will completely resolve, but I think it's reasonable to think about reducing the dose if you suggested and continue treatment with some supportive therapy for the neuropathies or fatigue if they need it. I think many of them already come in pre-treated with cis, and so you may already see some of that that's held on since they're neoadjuvant cisplatin.
Yeah, I would agree. I think that the data that Petros was citing was from the EV 103, 201, and 301 studies, which were earlier studies with this treatment. And the numbers of patients at lower doses are actually fairly limited. But we used a different schedule that's used in this particular trial, EV plus Pembro. EV plus Pembro was day 1, day 8. The EV301 is day 1, day 8, day 15 on a 4-week cycle. So it's a little different, but what we found from that trial is maintaining the dose intensity in the first 2 cycles was important to overall response, and then dose reduction subsequently didn't really change their outcomes. But you should be confident that you can hold doses for significant periods of time and still maintain response in these patients. And I think it's something you really got to work with the patient on, because they are very, very anxious and they don't want to lose their responses if they've had a great response to begin with. So I think you have to adjust it based upon the patient, based upon where they are in the treatment cycle. I mean, I tend to continue treatment earlier rather than later.
Great discussion. I agree. I think it's a really, really interesting to see how different patients may have different preferences, but I think quality of life is important, as you both mentioned. And I think it's a balance between trying to achieve maximum response, disease control, and of course, longer survival, and also adjusting in order to be able to get the patient through therapy and optimizing side effect management and quality of life. So it's this tight balance and discussion with the patient. And we'll come back to that, Teran, with your segment later regarding timely recognition, anticipation. That was one of our objectives in management of adverse events. Let's move on to the next slide here. Dan, this patient seems to have further progression. I will let you present the rest of the case.
So after that initial response, the patient then progressed in liver, and we did next generation sequencing on this patient, determined that the tumor was FGFR3 wild type and a low level of HER2 expression 1+. He went on to receive 6 cycles of carbogem, get a partial response after 3 cycles, and then cancer progression after 6. So at this point, what's the most appropriate treatment option? Erdafitinib, trastuzumab deruxtecan, sacituzumab govitecan, or paclitaxel or docetaxel. And we chose sacituzumab govitecan.
I agree, Dan, and I think, as you mentioned, the response duration with EV-pembro is usually long. As you pointed out, the median PFS is about a year, doubling of the median PFS and doubling of median OS. But the big question is, as you pointed out in your conclusion slide before, is what do you do in the case of a progression, whenever that progression may come? And in that scenario, we don't have really prospective data, as you alluded to define the second-line therapy post-EV-pembro. I think there's a lot of discussion in conferences and some articles out there. I think the option of doing platinum gemcitabine is a very reasonable one, trying to move it kind of a line later. And I think that was probably a significant portion of patients in the V302 trial got platinum gemcitabine. As Teran mentioned before, some of those patients may have neuropathy because of EV, so cisplatin may be a challenge. I think that patient with that profile of FGFR3 wild type, IHC was only +1, not enough for trastuzumab deruxtecan. I think carbogemcitabine was a very reasonable and standard second-line option. And as you pointed out, Dan, now after progression on carbogem, now we're at the third-line space. Again, ERDA option A and TTXD option B are not an option. I think sacituzumab govitecan is a really a great option at this point. I think that you would probably agree that if you use sacituzumab, you would probably use growth factor up front with as a primary prophylaxis, right, in the first cycle?
Absolutely.
Teran, any comments on that and the use of growth factor as a kind of mandatory?
Yes, absolutely.
For sacituzumab. So great take-home point for the audience. If you use sacituzumab, definitely growth factor in the first cycle as primary prophylaxis, trying to reduce febrile neutropenia events. And we can discuss a little bit more about that in a second. So we can continue down with the rest of the landscape here. We'll can go to the third trial, talk about erdafitinib. I will let you take over.
So for those patients who have FGFR3 mutations, THOR-1, I think, is an important study. So this study took patients who were 18 years of age or older with metastatic or unresectable urothelial carcinoma, confirmed disease progression, prior treatment with a checkpoint, 1 to 2 lines of systemic therapy, and they were selected based upon FGFR3 or 2 alterations, and they had to have an ECOG performance status of 0 or 1. They were randomized on a 1-to-1 basis to receive erdafitinib or dealer's choice chemotherapy, which could be either docetaxel or vinflunine. The primary endpoint was overall survival, and this trial demonstrated about a 4-month improvement in overall survival, with the median OS being 12.1 for those patients treated with erdafitinib, and 7.8, which has been consistent with previous chemotherapy trials for those patients who were treated with the standard care arm. The median progression-free survival was also better in the erdafitinib arm, 5.6 versus 2.7 months, and the objective response rate, 45% versus 11%, was superior in the erdafitinib arm. And as we see with other studies, when we look at different subgroups, age, gender, FGF alteration, the hazard ratio does seem to be a little bit different in the FGFR3 R248C mutation, but numbers are very small, so you really can't make any comparisons. PD-L1 status, higher PD-L1 levels seem to fall on the other side of the hazard ratio, and primarily upper tract tumors seem to do a little bit better than lower tract tumors, which may have something to do with FGFR3 expression in the subtypes that are seen. If we look in terms of the OS benefit, it all seems to be very, very similar based upon the individual subgroups. Phase 3 the Thor study took patients, erdafitinib versus pembrolizumab, in those patients who have FGFR3 mutations. They had to have confirmed disease progression on one prior treatment, they had to be naive to a PD-L1 inhibitor, and they had to be selected based upon the FGFR3 status, and patients were randomized to receive erdafitinib or pembrolizumab. As we see in this particular slide, the median overall survival for those patients treated with erdafitinib was 10.9 months. It's 11.1 months for those patients treated with pembrolizumab. And if we look at the progression-free survival, it's a little bit better. Hazard ratio 0.88, but not significantly different. And the objective response rate with erdafitinib was 40% versus 21.6% with pembrolizumab. And the pembro had a higher duration of response, 14.4 months versus 4.3 months. The safety profiles are different. If you look at the erdafitinib group, about 15% of patients discontinued erdafitinib due to treatment-related adverse events. 13% had serious treatment-related adverse events. There were no deaths attributed to drug on this trial, and most of the treatment-related adverse events were manageable. And these included hyperphosphatemia, stomatitis, dry mouth, oncholysis, hand-foot syndrome, as well as hyponatremia. So if we look at EV-101, which was a phase 1 trial of EV monotherapy that took doses between 0.75 and 1.25 milligrams per kilogram given on 3 out of 4 days, 4-week cycle, day 1, 8, and 15. The EV-201 trial, which was 1.25 milligrams, the established dose from the phase 1, having 2 different cohorts, patients who were previously treated with platinum-containing chemotherapy and anti-PD-L1 therapy, as well as those patients who were previously treated with anti-PD-L1 therapy and who were cisplatin ineligible, and then those patients from 301, which again administered the same dose and schedule to those patients who had prior platinum-containing chemotherapy and anti-PD-L1 therapy. We take this data and combine it together, we could see a very, very interesting pattern. Overall survival seems to be being about, from the 201 cohort, was 12.4 months. And we see from the EV-301, the overall survival was 12.9 months as well. Objective response rates were similar across these different groups. They were between 41.4 and 41 and 52%. Excuse me. The objective response rate was similar in these groups, ranging from 41 to 52%. And we have similar time to response. I think this is, again, one of the important characteristics of enfortumab. The responses are usually very, very rapid. Similar duration of response is progression-free survival, and I mentioned before, overall survival in all these particular arms. Next slide, please, of particular studies. And what we found was that the treatment-related adverse events were similar in different groups. Any treatment-related adverse event, 94%. Those requiring dose reductions, about 30%. And as we said before, peripheral neuropathy, skin rash, and fatigue are the most common side effects seen with these drugs.
Perfect. Thanks, Dan. This is a really great discussion. Maybe before we go to the sacituzumab data, maybe we'll take a quick second just to discuss, the three of us, regarding patient selection for a particular treatment. I know it's very difficult, of course, to select a treatment if we don't have definitive comparison data. For example, Dana, may start with you. If we have a patient who, let's say, was started treatment, before the pembro data came about, and they got, let's say, a GemCis followed by avelumab maintenance, and this patient has been doing well for a while and now has progression. And let's say that patient, after chemo or avelumab maintenance, has an FGFR3 mutation or fusion that is activating, and let's say that patient is eligible for erdafitinib. how would you make the decision between enfortumab vedotin based on the data you just showed versus erdafitinib in that patient post-chemo and checkpoint inhibitor?
Well, the way I would make the decision, I think, is based upon toxicity. There have been some studies that have shown similar response rates and progression-free survival in FGFR3 positive patients for erdafitinib as well as enfortumab. I tend to go with enfortumab first because I think some of the side effects seen with erdafitinib can be a little bit difficult to manage, particularly the optic dysfunction that can occur. Central serous retinopathy is seen with this, and this requires that the patient be examined on a monthly basis by an ophthalmologist. So it's a little bit more cumbersome to administer. And also, I think the fatigue is, in my clinical experience, is somewhat more intense than it is with enfortumab. So I tend to use enfortumab in the general patient if that peripheral neuropathy or other side effects that may be relevant to enfortumab, particularly if they're diabetic and they have problems controlling their diabetes. I think those two are more reason to go during erdafitinib in that situation. So without really good randomized data, I think toxicity is a good way to select treatment.
I agree, Dan, with you. I think you outlined it so well. I think toxicity profiles and medical comorbidities of each patient, as you mentioned, history of significant neuropathy grade 2 or higher, or uncontrolled diabetes, or maybe liver cirrhosis, maybe another factor to consider in that balance of pros and cons. We see some anecdotal higher toxicity with enfortumab in the context of liver cirrhosis. Of course, this is a discussion with the patient in the absence of definitive data. And as you pointed out, oral versus IV, distance from the cancer center, compliance, ability to swallow and tolerate PO agents, and of course, patient preferences. I think all of those factors can play a role. Karen, any comments on your end in that context?
No, I think you both outlined very well how the treatment has to be individualized. The other thing to think about is we'll talk about this later, but this is a great place for shared decision making, because you may be telling the patient, I really think this is what I prefer for you, but given your fatigue or given your neuropathies, I really want you to understand that I'm offering a different treatment, which I think may be a better choice for you, and understanding their goals of care, their goals of therapy, how their quality of life. Is their neuropathy affecting their ability to function every day? I think trying to put that together is important. Patients may just say, whatever you decide, doctor, I want you to treat me. I want to be treated. But we have to think about helping them understand why you're making that decision between two good treatment options, and how their, as you said, comorbidities and their other effects from prior therapy may influence what you're going to offer them.
Very well said, Aaron. Thank you. And you pointed out there's importance of important shared decision making, and we'll come back to that in a few slides. And all those factors and nuances, sometimes we even wonder in the molecular level, if you have an FGFR3 mutation versus fusion, does this matter because we have less patients with fusions in FGFR3? Is that a decision point or not? Hard to tell. And of course, other nuances, as you mentioned, Dan pointed out the need to see an ophthalmologist at baseline and during treatment with erdafitinib, the FGFR inhibitor. And that's another important factor, because access to those subspecialists could be a challenge sometimes. And the timely access, as you said, both in terms of managing side effects, but also for erdafitinib to make sure that someone has evaluation at baseline and do a good look at the cornea, the retina, and optical CT are important. And of course, looking at labs, at phosphate levels, all those factors. So it's definitely a great, I would say, and balanced discussion about pros and cons for individual decision making. With that great discussion in mind, and I know we have so much to cover, so I will move on with the sacituzumab govitecan data. And we just talked about Dan's case a few minutes ago. I think sacituzumab govitecan is a very important agent. It's an antibody drug conjugate targeting TROP2 that is expressed significantly in the membrane of urothelial carcinoma cells, and we have seen that in a lot of early data. The structure of the molecule and of the compound is shown in the left upper corner. You see there is an antibody, as Dan pointed out before. The antibody is targeting TROP2. There is a linker, and the linker is as you see, has a pH-dependent cleavage site and can be hydrolyzed, and that links, conjugates the antibody with SN38. That's a very potent active metabolite of irinotecan, a topoisomerase 1 inhibitor that I think may explain also the toxicity profile of this antibody drug conjugate. On the right part of the slide, you see early data from phase 1 trials looking at the response rate, and you see approximately 31% response rate, very promising with this compound as monotherapy in previously pretreated patients with advanced urothelial carcinoma, with a promising signal in the PFS and OS in the single-arm monotherapy trials. Based on this early phase 1 data, with Dr. Petrlak and others, we designed the Trophy trial. This is a multi-cohort phase 2 trial looking at sacituzumab govitecan as single agent, but also in combinations. And we have seen data so far from cohort 1, 2, and 3. We have not yet seen data from cohorts 4, 5, and 6, but we can look in the future for those cohorts 5 and 6, 4, 5, and 6 data sets. But briefly, I can cover the cohort 1, 2, and 3 data here in the next few slides. I think it's important to note that cohort 1 evaluated sacituzumab govitecan, let's call it SG. SG was given as monotherapy in patients with previously treated metastatic urothelial carcinoma. These patients had to have prior chemotherapy, platinum-based, and checkpoint inhibition. And some of those patients, actually 10 out of the 113 patients in the trial, had prior enfortumab vedotin as well. Majority of patients, as I mentioned, did not have a prior EV because the cohort 1 study was conducted earlier in the days, and it depends, of course, on when the enfortumab vedotin got the approval. And this was, I think, December 2019. So depending on the timing and where the study was conducted, some patients may or not have had access to a prior enfortumab. Having said that, you see that the response rate with longer follow-up actually achieved 28% with SG monotherapy in previously treated patients. These are patients heavily pretreated. Many of them had multiple lines of prior therapy. And despite that, you see a very, I would say, robust activity. You see the waterfall plot on the right, that about 3/4 of the patients had reduction in the tumor size on imaging, again, showing activity of this compound. Response rate, as I mentioned, 28%, and the median duration of response about 6 months, and rapid responses with usually responses noted at the time of the first scan. You see in this slide on the left, the swimmer's plot, on the right, the spider's plot, and what you see is what I just mentioned. Most responses come early on at the time of the first initial scan, and some of the patients, a proportion of patients may have durable responses. As I mentioned, the median duration of response was about 6 months, and resistance may happen eventually in the vast majority of patients. There are very few of them who may have long-term response and may go beyond a year, but these are exceptions. But there are a few patients like that. Toxicity profile, I think, is explained to a significant degree by the structure of the antibody drug conjugate. As I mentioned, a topoisomerase 1 inhibitor, SN38, a metabolite of irinotecan, is the active payload. And as you expect here, hematologic toxicity, neutropenia, febrile neutropenia can happen in about 10% of patients. And I think we all made the point before that if you use this compound, you need to use growth factor as primary prophylaxis with the first cycle of the drug. Short-acting or long-acting growth factor is important, and we can discuss nuances if needed, but I think it's important message to do that as primary prophylaxis. Diarrhea can happen in about 2/3 of the patients. It's usually grade 1, grade 2. It's important to, as we discussed before, anticipate, and Taran can talk about that in a second, and educate the patient early on if they have diarrhea to let the team know, make sure, of course, there's no infection, and use anti-diarrhea medications as needed. Loperamide, phenoxylate are usually effective in most patients to manage the diarrhea. As you see, fatigue, alopecia, anorexia may be other side effects with this compound. Here, a very brief cohort 2 data that Dr. Petrolak presented at a previous meeting, and the manuscript actually is in press and will come very soon at the prestigious journal. Dr. Petrolak showed that this cohort 2 took patients who were cisplatin ineligible and they have progression on prior checkpoint inhibitor given as first line, and tested sacituzumab govitecan kind of a second line as monotherapy. The primary endpoint was overall response rate, and 38 patients were included in that cohort 2. Again, SG monotherapy in patients who had progression on prior checkpoint inhibitor. Response rate was 32%, again showing activity. You see the response rate of these were all partial responses. A proportion of patients had stable disease as best response status, and as I mentioned, a third of the patients had partial response. A waterfall plot on the right upper corner and the swimmers plot on the right lower corner. You see most responses, if they happen, usually come early on in the first scan or so, and a few patients may have durable responses. This is the PFS and OS curves. Again, we take them with a grain of salt because it's a single arm phase 2 study, but I think it's definitely a promising signal here for survival in that context of a single arm monotherapy trial with sacituzumab govitecan second line after checkpoint inhibitor. In this cohort 3, we had the chance to publish the data with Dr. Petrolak and others at JCO recently. This is a cohort of 41 patients getting second line platinum refractory patients who could not get maintenance avelumab because of progression on platinum-based chemotherapy. They got SG plus pembrolizumab combination. This is second line, and the response rate was promising, was 41%. About half of them were complete responses, and the other half partial responses. Median duration of response about 11 months, median PFS 5.3 months, and median OS a little bit more than a year. Again, this is a single arm, not randomized study like cohort 1, cohort 2. Also, cohort 3 was single arm study, but I think the signal was promising. You see the spider plot on the right upper corner and the waterfall plot on the right lower corner. Based on this promising signal, this is not practice changing, but definitely supports an soon to be launched phase 3 trial looking at sacituzumab govitecan alone, or I will show you in a second combination, and I will show you the study schema in a second in a cooperative group trial. Before I do that, I want to show you the press release from the TROPIC-04 trial. This is a phase 3 trial that was designed to confirm the data from the cohort 1 of the TROPHY-U01, the phase 2 trial that I showed you a few slides ago. This was sacituzumab govitecan single agent given on days 1 and day 8 on a 21-day cycle, exactly as it was given in the TROPHY trial that I showed you, compared to docetaxel or paclitaxel. And that trial had the primary endpoint of overall survival. We have not seen the data yet, and we plan to see the data in the future. However, the press release showed that there was no overall survival difference between the two arms. There was some discussion about some neutropenic events, and I think that reinforces the point, reiterates the point we made before, that if you use sacituzumab govitecan, make sure you use growth factor as primary prophylaxis from the first cycle, and we anticipate the data of this phase 3 trial in the future. What I alluded before is that based on the cohort 3 data, Saci plus Pembro combination, the Saci plus Pembro is not ready for prime time. However, this phase 3 trial, the ECOG-ACRIN 8231, is going to ask the question of IO rechallenge. We do not have much data about the rechallenging patients with checkpoint inhibition if there was prior progression on checkpoint inhibitor. So that trial will try to answer the question. ECOG PS022, prior immunotherapy is mandatory. Prior EV and platinum chemotherapy are allowed. Patients may have a limit up to 2 or 3 lines of prior therapy for metastatic urothelial carcinoma and have measurable disease. They will be randomized to Saci plus Pembro versus Saci alone to see again the checkpoint inhibitory challenge question. You see the stratification factors on the lower part of the slide. Primary endpoint will be overall survival, and we're hoping to launch this phase 3 trial in the future to answer this IO challenge question in that design. Now, having said that, I think we can go back to the case, and then I will turn it back to you to discuss this further continuation of the case. Thank you.
Thank you, Petros. For this patient, he was able to control his diarrhea at home with loperamide and diet modifications as needed. He presents for cycle 5, day 1 of sacituzumab with an ANC of 1100. His vital signs are stable. He's afebrile. You contact the physician with the lab results, which are the following is the most appropriate step. Continue SG infusion as planned, but order pofegrastim to be administered within 24 to 48 hours of post-dose. Hold SG until the AA recovers to 1500. Continue SG infusion as planned, but reduce dose by dose level 1. Continue SG infusion as planned without dose reductions. So what I would do is I would just hold the SG until the patient recovers to more than 1500.
I fully agree, Dan. I think it's day one of the cycle. I think ideally we want the ANC to be at least 1500, as you mentioned, and I would do the same thing with you, option B, and I would make sure that the patient, if the patient was not on growth factor before, I would definitely make sure that the growth factor is given. Taran, any comments on your end?
No, I agree completely. We've talked about this, but we know in this population that an ANC needs to be 1500 or greater for us to continue. So it's really important, even though in other patient populations, we may have tolerated something lower.
Thanks, Taran. I agree. And especially for day one. I think for day 8, have you used the lower threshold, like 1000 on day 8? Dan, maybe I'll start with you.
I can do that. I have no problem with it because that's when we can administer the last at that particular point. And 14 days. And I think that you can cover the patient and monitor the patient carefully at that point.
Yeah.
Thanks, Dan. Taran, you agree with that?
I agree.
And thank you both. And let me ask you, where do you use the growth factor? Do you do it on day 8 after day 8 dosing as a pegfilgrastim? Do you do daily injections on like day 2 to 6 and 9 to 14? What's your kind of preferred way of using growth factor with sacituzumab?
I actually use it from day 2 to day 7, and then give them a dose of a 14-day dose of GCSF on day 8, usually by on-body injector. So I've seen patients drop their counts in the first cycle immediately. So I'm very, very conservative about this situation.
Thanks, Dan. Great points. Taran?
We would use it on day 2, daily, starting on day 2, and then look for the injector by day 8 if possible.
Got you. So you both do the same. You do day 2 to 6, let's say daily injections, and then you go with the injector on day 8 after the day 8 dosing. And your goal with that strategy is to try to preserve day 8 dosing, sounds like. Gotcha. Any issues with insurance coverage of that, or you have been successful in getting that authorized?
I've not had any issues.
We've not seen a lot of insurance issues with this. A lot of our patients do not live in the area where they're being treated. So patients are frustrated by the fact that we want them to stay around. We don't want them going home until after day 8 when they have the injector. So it's much more, I think, instead of insurance, negotiating with the patient and their family about the need for them to be treated daily until we get through day 8.
Got you. So patient familiarity of, and let's say comfort of doing the injections, either self-injections or a caregiver versus coming to the clinic, as you pointed out. Got you. Great discussion. I think it's a great segue. Maybe we can go, Taran, to you next. And I will put the slide here for you because there's so many components when we talk about, education of patients and toxicity, anticipation and management. So I will turn it on to you to educate us. Thank you.
It's interesting, but I think one of the most important things to think about is these patients belong to a large team. And for example, while they are being managed by medical oncology, they may still have a strong relationship with, for example, urology. We do a lot of education with our urology residents, so they understand a patient's call about diarrhea, for example, is a very serious call. Many people feel, well, we know about diarrhea or we know about fatigue because of prior chemotherapy treatments. We know it's the same. It's not the same in this patient population. It's very important that the person they're talking to understands the relativity of their described side effects or how to interpret their blood work. So the neutropenia, as we saw, possibly life-threatening, so very important to be addressed. You want them, logistics play a role. I mean, where are they getting their blood work? Who can see the results of the blood work fairly quickly after it's done? Not that you're waiting on a fax to come from a community lab where you don't know where the blood work is. So that's very important. And of course, the diarrhea, very important to make sure the patient actually can manage some home regimens for treating that, and they know who to report that to. Of course, AEs of special concern include hypersensitivity, the nausea and vomiting. Everyone says, well, we sort of know what to do about nausea and vomiting. We knew how to manage that with chemotherapy. But increased risk of adverse reactions with these patients with reduced UGT1A1 activity. And of course, we have to think about patients with the potential in all of these medications about embryofetal harm. Who's handling any medications that may be working with the patient while it might be a male patient? Is it a female helping with any of their medications, or they're filling their pill box, for example? So we talk a lot about that when we're helping patients understand the warnings about this medication. We talked about GI a little bit, and we'll hit on that in just a moment. So I think you both have talked about this, and I'll let you comment. But remember, we've all agreed that G-CSF was not, while it may not have been in the clinical trials, we think it's very important starting on day 1. Certainly by day 2, we're talking about getting started with daily and monitoring their blood counts, holding for any ANC less than 1,500. And certainly by any later in the cycle, day 8 or 15, an ANC of less than 1,000, but you want to know that they're on some growth factor. And it's based on what we've talked about earlier, dose reductions are indicated. And there's a nice schematic here showing as first recurrence, you can reduce the dose. Second recurrence, you've got to think about a 50% dose reduction. And if they're going to have a third recurrence and you've managed them tightly and still they're having it, I think you have to think about discontinuing. So I think GI toxicities are best understood by the medical oncology team. And certainly that's who you want the patient talking to if they're having these toxicities, grade 1 and 2. If you feel like you can manage them at home, that's great. But grade 3, you probably want to bring them into the hospital. Nausea and vomiting, usually we have some, you have some ideas about that in terms of how to treat that. But diarrhea, you want to make sure that they can keep up with their fluids and they've got something there ready to manage the stools, loperamide, for example. And if they're not managing it, even if it's a grade 2, but they are not able to keep up, then you have to think about bringing them in for some hydration. You might bring them into the infusion center for hydration, or you may bring them into the hospital if you think they're just getting behind. Constipation, I think it's occasional intermittent, but usually that's pretty easy to treat. You have to think about what kind of laxative you're going to use. Should they be on a stool softener regularly, or something that's a moderate stimulant without causing them to have profound diarrhea as a result of laxatives, because then they may be in that cycle of, again, diarrhea that causes dehydration. Certainly grade 3 or 4 of any of these GI toxicities, you're wanting to bring them in and decide how you want to manage them in the hospital at grade 3 to sort of reverse the course, if you will. So I'd be interested to hear what the two of you all think and how you do it in your regimen. I mean, you can treat these patients acutely and early on after the infusion, make sure the patients understand what to report, make sure we have available in the clinic what you can give them as an outpatient to keep them in the ambulatory area if possible. But if they're having that delayed effect, you want to think about infection. If it's negative, you can start them on loperamide. You've got to get a stool specimen somewhere that somebody can be looking at before you start the loperamide. And then you have to decide if you can continue to manage them as an outpatient. How do you all do this in your centers?
Well, my center, we try to catch them early. So, we try to get them on loperamide early. After the stool, it's, as you mentioned before, a team approach here is really, and making sure that the physician and the nurse practitioner or the PA really carefully explain toxicity to the patient. Also follow up, because sometimes patients don't really really appreciate the toxicity until they're actually there. So I've used octreotide in severe diarrhea, which has really helped a lot also.
And can I ask you, have you had trouble getting that covered in the ambulatory setting because of insurance?
No, I have not.
Good.
I agree, Taryn, with Dan. I think we have a pre-med built in the electronic ordering system for atropine, just in the uncommon case of an acute cholinergic syndrome reaction. So we have atropine IV ordered as part of the order set. This is not common. We have not seen that much in the clinical practice, but we have it built in just in case. And the delayed effect is probably more common. And as you pointed out, we want to make sure there's no infection. And if the story fits, right, based on the history and the timing, usually we see this diarrhea temporarily related a little bit after a few days after the infusion of sacituzumab. If it looks like as an adverse event of treatment, I think starting promptly early with loperamide or difenoxylate is usually effective. And most of those diarrhea episodes are grade 1 or grade 2, well managed. And as you said, you and Dan mentioned, if there is a need, we may bring the patient in for evaluation on IV hydration. Rarely we have needed to do something more, let's say, intense like octreotide, but it's an option. I think usually the anti-diarrhea medications and plus minus IV hydration, if needed, usually are adequate to manage those patients. And as you pointed out, education can help a lot to anticipate and recognize it optimally, because the drug is active, has significant activity. So optimizing the side effect profile can help optimizing the risk-benefit ratio.
I think we talked about this. Again, discussion of, do you need to hold treatments? Certainly if they're grade 3, you may hold treatment until you get it under control and get the symptoms down to the grade 1 or less, and then resume. Would both of you do then at that point a level 1 dose reduction?
I agree. Yeah, depending on the grade. Yeah,
I agree as well.
Great. Thanks, Darren. It's so much, to talk, and all three of us agree that sacituzumab govitecan is an active agent, has activity in urothelial carcinoma, has an accelerated FDA approval for patients with previously treated advanced urothelial carcinoma after chemotherapy and after checkpoint inhibition. And I think it's important to understand, again, the benefits and risks. This slide is about the UGT1A1 polymorphisms, and there have been efforts in the literature to try to evaluate the frequency of those polymorphisms and whether there's any association with higher toxicity with sacituzumab govitecan. The reason is because, as I mentioned, the SN38, the metabolite, the payload, is a metabolite of irinotecan, and that can be metabolized by UGT1A1. I think the take-home point, and tell me what you think, is usually we do not routinely test for this polymorphism in clinic. We do it only, at least in our practice, reflexively, reactively, in a rare case where we have an out of proportion side effect or toxicity reaction for the patient with significant neutropenia, despite growth factor primary prophylaxis or significant diarrhea. Then we may do it on a case by case, but we don't routinely use it, upfront. Great discussion. I think, and as I mentioned before, the use of growth factor is particularly important for the population we discussed today, which is patients with metastatic urothelial cancer, because almost all those patients meet one of the ASCO guidelines for neutropenia risk. And this population is particular and may have differences with other populations. So I think this discussion about growth factor primary prophylaxis is particularly important for the urothelial carcinoma patient population. Darren, back to you to discuss a little bit about informal vedotin and toxicities and anticipation and management.
So again, very important to make sure that the patient, their family, their caregivers understand the warnings about cutaneous adverse reactions and about epidermal necrolysis, hyperglycemia, pneumonitis, interstitial lung disease. Usually you're hearing something about that, or you're thinking about that as you're looking at their scans or as they're reporting any shortness of breath, and should you get another film. But their ocular disorders is something we're going to talk about in just a moment, but it's very important to think about that. And these patients hopefully have had a baseline ocular exam with their ophthalmologist. And again, if you think about hematologic issues, their hemoglobin and their lymphocytes, you have to keep an eye on that. Lab work's very important. And of course the GI. But when you think about key things, I think here we're thinking about ocular disorders and again about rash. So we can talk about skin reactions with EV. Pretty high percent in grade 3, 58%, all grades, 14% grade 3 to 4. They can get this macropapular rash, this erythematous rash, or even a drug eruption. And they can also get this symmetrical drug-related intertrigonous eczema. obviously blisters or bullae sometimes, and even that exfoliative dermatitis. But it's important that we have had patients who live in distance from the oncology cancer center, who may be thinking they have a rash, forgetting their education about who to report the rash to, thinking their dermatologist could help them with a rash, or they would just use some creams they have from before. So education is very important, that the patient understand that this is the kind of skin reaction, any level of grade 1, 3, or 4, 1, 2, 3, or 4. We want to hear from the patients about this. We don't want them seeking treatment or using something that their partner or spouse or family member has around for a rash. Oh, I had some cream that I thought I could put on this, or it was a bullae, but I didn't think it was related. Very important. And the onset is usually at about weeks later, not right initially. So it's important to think about how they know what to report and checking, or you may have someone on your team, one of the nurse coordinators, maybe checking in with patients as they move along in treatment. And if patients can have complete resolution, we saw 58% complete resolution, but I think it's important that we be able to intervene early and hear from the patient when they're starting to experience these. This is a great slide showing the different potentials for grade 1 and 2. You can give supportive care, and you can offer a topical anti-infectives. You can use some triamcinolone if that seems appropriate, but it's important. What's interesting to me is that this is one place that the patient portal and the electronic medical record can be very helpful. Patients can take a picture of their rash and send it in on the EMR for someone to see and decide whether or not they have to come into the center. We try to help patients understand it's fine to report a rash or to be in touch with us or send us a picture and we will call them back. I've had patients say, well, I didn't think the rash was that bad and I wanted to stay on treatment, so I thought I would just wait and see if it progressed before I notified you. And I think sometimes with all of these side effects, you'll have patients who hesitate to report their side effects because they're afraid you may stop their treatment or bring them in and hold treatment. So it's important for them to understand that we want to be in early on these, that we're happy to try to manage these grade 1 or 2 with supportive care, but at grade 3 or 4, we want to be hearing about it and we want them to come in and see us. So here's a patient case. I think, Dr. Petrolak, this is your case.
Yeah, this is, you said, an example of what we would see for a grade 1 rash. This is a patient who received 2 doses of enfortumab. He developed a generalized myalgia and excimerous eruption, the rash was pruritic and a burning sensation. Did not improve with Benadryl. He had 2 to 6 minute pink blanchable non-tender macules and thin papules. This is modified from Dr. Lecountre's paper. And the question is, what do you do with this patient? Do you treat through skin toxicity and start a topical steroid cream, dose reduce, hold EV, start your cream, or hold EV, start prednisone? My answer would be to treat through the skin toxicity and start triamcinolone acetate 1% and topical steroid cream.
And Dan, great case. Thank you for presenting, and thanks, Taran. Question for you, because I think if you have like a grade 3 case, I saw that the body surface area was more than 30%. Would that impact your decision in terms of holding EV versus continuing?
Definitely. Hold it, and then I would give steroids, oral steroids at that point.
Gotcha. I agree, Dan. If it is a grade 3, I would definitely hold EV. And to be honest with you, I'm just thinking sometimes even with grade 2, especially if it is a kind of extensive grade 2, I may hold EV. As you pointed out, Taran and Dan, skin toxicity can be an issue. And there is also the black box warning with Stevens-Johnson or TEN. So I tend to hold, I have a low threshold to hold EV for grade 2 and grade 3. And then the question becomes topical steroid versus systemic steroid. I think the more diffuse, we can start with topical steroid, but in more localized disease setting, and also depends on the symptoms like pruritus or irritation. But if the topicals are not enough, I may have a low threshold to go to oral steroid. Although there is all the discussion and debate about oral steroids. Taran, any comments on that in a grade 3 or grade 2 skin rash?
I agree with you, but I had a question for you. So if you held the treatment and treated the patient with prednisone what would your threshold be for restarting treatment? When would you decide to restart?
It's a great question, and I want to hear Dan's thoughts too. But the confounding factor here is pembrolizumab, which can also cause skin rash, and this can cause some confounding. But that's when we definitely pick up the phone, we call dermatology. Access to dermatology is another whole discussion. It will be ideal, I think, the dermatologist to see the patient. Sometimes we do a biopsy to learn from these cases and try to have a disciplinary, multidisciplinary discussion, interdisciplinary discussion with dermatology and say, what do you guys think? Is that EV related, pembro related? We have pharmacists involved in this interdisciplinary discussions, and we make a decision as a team with the patient. I would say if we think that this is not clear what is causing this grade 3, we may hold both agents, and we may reintroduce enfortumab and pembro if it goes back to grade 1 or less, and possibly with a dose reduction of EV. That's where we do a lower dose of EV. If we have strong feelings that this is caused by one or the other, we may potentially, continue the other agent. It also depends on what other side effects patients may have that may give you some hints. And of course, to your point, if you use oral steroids, that may be also time to hold off pembro until you have a taper in prednisone to a lower dose. And of course, the rash to be improved to grade 1 or less. So it depends on the severity, the extent, the grade of the rash, what we think is the attribution, the cause, and of course, in the interdisciplinary approach with dermatology and pharmacy can also help in those discussions. Dan, any comments on this?
Well, yeah, I mean, going back to grade 1 is where I would start. And the other thing, too, of course, to remember is that you want to look at the course. Usually, the skin reactions are early. So from the data we talked about before, you really want to get the doses in quickly. So the quicker you can get these patients back on treatment, the better.
Thank you.
Great discussion, and I think having this tool, the electronic health record, and taking pictures and the patients to definitely alert us early on is very important to avoid underreporting, because again, with grade 2 and grade 3 rash, we all have a tendency to hold off EV. We think that's potential cause of the treatment. Grade 1, it's maybe different. That may be case by case, and the discussion is, what do you do in the grade 1? I think it depends on the scenario, and we have generally, as we discussed before, a low threshold for those reductions if needed after discussion with the patient. Karen, maybe go back to you for erdafitinib.
Yes, let's talk about areas of special concern at adverse events. So ocular disorders are the potential, and this is where you need the patient to have a relationship with an ophthalmologist. That can be challenging. If they're going to stay at an academic center, then you'd like to think that you'd partner with that ophthalmology team before you begin treatment so that they can tell you their regimen and how they would have someone see the patient either urgently and on a regular basis. We very often we'll collaborate with them and make sure there's a resident or fellow who's available if we want someone to be have an exam out of schedule. Also, this is a great area where you think about hyperphosphatemia. That's collaboration with both your nutritionist for dietary counseling with the patients and helping monitoring the lab work, but using that resource to help you decide how the patient can restrict their dietary phosphates. And again, talking about medications that other family members may be helping with. You want to think about embryofetal toxicity and making sure there's no handling of the medications by other family members. Again, GI side effects, about 63% report diarrhea. So it's important to think about to make sure the patient has a plan for dealing with that at home. And stomatitis, we all feel like we know how to deal with that based on prior chemotherapy exposure and experience. But again, we want the patient to be reporting that. And we've talked a little bit about skin disorders. Again, we talked about this, but here's ocular toxicity. You want a baseline, and then remember that the first time to onset is about 46 days. So you want to already have a baseline with the patient and have the ability to get them back in to see ophthalmology if needed. It's a low risk of grade 3, only about 3%, but very often if they're experiencing that, you may have to hold the dose, you may until they've resolved or improved. Remember, the dry eye symptoms occur in about 28% of patients, but grade 3 in about 26% of patients. So they need a plan. They need an ophthalmologist who understands what you're going to be treating them with and ability to collaborate with you on the care of the patient with those monthly exams during the first 4 months and then every 3 months after. And the urgent exams just as important, and that can be the most challenging for people out in the community to make sure you have a plan for that as you begin. This is where your nurse coordinator or your APP may be very helpful in collaborating with the patient's ophthalmologist to make sure that they can get in for an exam. So I think if we've talked about this all around today, that the patient and their caregivers at the center of our care, but a lot of team members involved in providing optimal management. It does take a multidisciplinary approach. Providing them with the best management relies on really good collaboration and teamwork among all members of the team, the urologist, the radiation oncologist, of course, the medical oncologist is the driver of the plan, but their care coordinator or oncology nurse, the pharmacist, the nutritionist, everyone involved having the ability to collaborate and having a good communication pathway for managing these patients safely. I thought the ASCO endorsement was excellent. Multi-D input via tumor board discussions, interdirected consultations is critical. We do a lot of education with our resident teams in urology, in radiation oncology. We want those teams to understand what these patients are being treated with so that anyone who receives a call from the patient understands how to communicate within this network of caregivers for optimal care. And again, we started early talking about this, and I think it shows how important it is when you think about the potential side effects of these medications. Shared decision-making is very important. Up front, the physician, the medical oncologist, and the APPs thinking about therapeutic advances, clinical trial offerings, what are the resources to help us guide treatment selection, and when should the patient have biomarker testing. The support staff are there to give the education to the patients and their staff, to help patients have tools to aid their decision-making and implementing the protocols to mitigate new shortages. But the patients need to be allowed to ask questions and encouraged to ask questions. And really, the staff and the physician team really want to understand the patient's goals of care, we want the patient to understand their treatment options and selection potentials, and then how we can continually offer them enrollment in clinical trials as it's appropriate. But the shared decision-making is really important when you, as the oncologist, have choices of how you might treat the patient or the choice about going on with treatment or holding treatment based on how they're feeling during treatment. So the shared decision-making, very important, and it does involve every member of the staff. Thank you.
Wonderful discussion. Thank you, Tara. And as we wrap up here, I want to thank you and Dan. Fantastic discussion. And I can say there is so much to cover, and we tried our best to be updating our audience about all the amazing developments and the revolution in the field of advanced urothelial carcinoma. I think we have some what we call SMART goals here, which is the takeaways, measurable and relevant goals. I think it's important to take all these data sets and put them into action for individual patient care and informed shared decision making, as Taran pointed out. A few takeaways from this program. I think we'll agree that implement thorough and detailed patient education to help patients recognize potential adverse events is very important. Across treatments, including antibody drug conjugates, provide very clear guidance on the next steps to take and ask the patients to report very early in a timely manner and accurately to avoid underreporting. Of course, we want to enhance patient understanding of their care team by making sure that patients and the caregivers are very familiar with the team members, the providers team, and also how and when to contact each of the team members. It's very important to have this communication very, very tight and well described. We discussed already about using growth factor as primary prophylaxis with the first cycle when we use substitution govitecan in patients with advanced urothelial carcinoma, because as we mentioned, this patient population in particular meets almost in all cases the ASCO guidelines that provide guidance for neutropenic events and neutropenic fever risk. And that's important to take into account. And of course, communication is key. Clinicians, we want to be proactive. Education is key to provide educational tools with our patients and caregivers, ask them to ask questions and assess, of course, disease burden and impact on quality of life all the time. I want to thank again Tara and Dan, fantastic CME event today. And for the audience to receive CME and C credit for this educational activity, participants must complete the post-test and evaluation online. We would like to get your feedback. This is very useful to us to keep improving. So thank you in advance for doing that. And to provide feedback, I think you will help us for future projects and educational products. Please click on the request credit tab to complete the process and print your certificate. And with that, I would like to thank you so much for the attention and the time today. Thank you so much, the audience. Thank you, Tara, and thank you, Dan, and the organizers.
Thank you.